All these topics are very important today, and Dr. Jaya will be talking on organophosphorus compound poisoning management. It is one of the topics which is classified under the toxicology, where as an intensive care specialist, sometimes if you are going to manage toxicology also, you will be seeing patients who have either intentionally taken or accidentally got exposed to organophosphorus compounds. And you must know what are all the various clinical presentations and how to manage these cases. So from that angle, Dr. Jayabharti will be now presenting the management of OPC poisoning. You can go ahead, Doctor.
Yes, sir. Good evening, sir.
Good evening.
So my topic is on organophosphorus poisoning. Organophosphorus compounds are derivatives of phosphoric acid. They are mainly used as insecticides and also as nerve agents. That is, they are used as chemical warfare agents. Organophosphorus compounds inhibit acetylcholinesterase activity. Then, so the main action is to inhibit acetylcholinesterase activity, which is resulting in cholinergic overstimulation. Coming to the classification, they are classified as alkyl phosphates and aryl phosphates. The compounds include HETP, malathion, OMPA, trichlorophos in alkyl phosphates, and in aryl phosphates, parathion, diazion, paraxoxone, methylparathion, and chlorothione. These are some of the organophosphorus compounds. Coming to the absorption of these chemicals occurs either through inhalation and also by ingestion and also through the skin and the mucous membrane. The insecticides are oily and it is less volatile, acting with a longer time of onset and longer duration of action will be present. Whereas with the nerve agents, they are typically watery and they are volatile and they act rapidly and severely, but for a shorter period of time. And these nerve agents are highly toxic, stable, and they are easily dispersed. The other type is carbamate insecticides. They have more limited penetration of central nervous system. Fatal period of action occurs within less than 24 hours if in untreated cases. Complete recovery occurs in 10 days if treated early. Coming to the clinical symptoms can be divided into immediate and delayed sequelae. Immediate symptom, the onset is most rapid following inhalation mainly, and least following the skin during skin absorption of the agents. It begins within 5 minutes, and usually the symptoms become more pronounced in 8 hours. The manifestations include first the muscarinic manifestation, that is salivation, lacrimation, urination, defecation, and in GI tract there will be hyperperistalsis, gastrointestinal pain and distress, and hyperemesis will be there. And respiratory tract includes rhinorrhea, bronchoria, bronchospasm. It also causes meiosis and blurred vision, and in serious it causes bradycardia and hypotension. And coming to the nicotinic symptoms, in striated muscles, it can cause fasciculation, cramps, areflexia, and paralysis. The most deadly thing is what is the respiratory paralysis and acute respiratory distress. In sympathetic system, it causes hypertension, tachycardia, pallor, and mydriasis. Coming to the neurological symptoms, it can cause restlessness, drowsiness, emotional lability, and slurred speech, headache, ataxia, tremors, weakness, and at last it can cause confusion, coma, and also convulsions. And the most pronounced symptom is chromolacturia, which is formation of red tears, which is more specific for OPC compounds. It occurs due to the porphyrin accumulation in the lacrimal glands. Coming to the delayed sequelae, it occurs in 1 to 4 days exposure. The delayed sequelae, the most important is the intermediate syndrome, which occurs, as I said before, in 1 to 4 days of exposure. It occurs in mostly 20% of the patients. Intermediate syndrome is due to the it occurs after the reverse in the cholinergic difficulty that has subsided, but before the onset of the OPC poisoning. Induced peripheral neuropathy. So it can last up to 5 to 6 days. It is mainly characterized by the sudden onset of muscle weakness that includes respiratory muscles inability and weakness of the muscles and the proximal limb muscle weakness. So lack of Paradoxic treatment and tissue redistribution are the main causes for the intermediate syndrome. It can cause respiratory failure and leads to intubation and mechanical ventilation. And the delay sequelae also includes the CNS effects, which can cause cognitive impairment, seizures, coma, and also central apnea. The main cause of death in patients with OPC compounds is acute respiratory failure, which is mediated by either bronchoria, bronchospasm, or respiratory muscle and diaphragmatic weakness and paralysis, and also due to the inhibition of the medullary respiratory center. So, this is the main cause of the death in patients with OPC compounds. Coming to the diagnosis, mainly the clinical diagnosis and symptoms. Signs, the patient will have garlicky odor from the patient. From that, we can diagnose OPC poisoning. And the other thing is atropine test can be done. 2 mg of atropine can be given IV, 6 mg as IM. If normal persons will have marked atropinization, whereas in OPC poison, the symptoms are relieved and the secretions decrease. And the other tests is RBC and plasma cholinesterase levels can be checked. A reduction in 50% of the baseline values will be present. And RBC cholinesterase is the more accurate indicator for the synaptic cholinesterase. And other non-specific indicators which can be used for diagnosis include leukocytosis, hyperglycemia, abnormal liver function test, and pulmonary edema and chest X-ray. An ECG can show prolonged QTs interval, heart block, and oscillating D pointers. Electromyography can also be done to help, which helps in diagnosing OPC poisoning. It quantifies acetylcholinesterase at the neuromuscular junction. Coming to the treatment includes general measures and specific measures. The general measures of a patient coming with OPC poisoning is first to remove their clothes, whatever the clothes they are wearing, to avoid the skin absorption. And the person who treats OPC poisoning can wear a nitrile gloves instead of latex gloves for a better protection. So first remove the patient from the source of exposure. Then remove all the contaminated clothing and wash the exposed areas either with water or and also with diluted ethanol, and irrigate the conjunctiva and skin folds, fingernails, scalp, whatever which infected with the OPC compounds. And the next important thing is securing the airway. Keep the airway of the patient patent. So gentle suctioning can be done because there will be more secretions. So gentle suctioning can be done to remove the secretions. An intubation or tracheostomy is needed if the patient presents with coma or bronchospasm or respiratory failure. Choline should be avoided because choline may cause prolonged paralysis. Stomach wash can be given in patients if the poison is ingested. Stomach wash with either potassium permanganate or activated charcoal 1 gram per kg can be used. And coming to the pharmacological treatment, it can be of 3 types. That is, it can give an anticholinergic drugs, same drugs, and anticonvulsants. Anticholinergic drug to counteract the acute cholinergic crisis. Yes, and an oxime drug to reactivate the inhibited acetylcholinesterase. An anticonvulsant drug to prevent the seizures. So anticholinergic, the most common we use atropine in 2 mg doses repeated 5 to 10 minutes. And it is the main antidote for this poisoning. Coming to the oxime drugs, the main drug what we use is pyridoxine. It restores the acetylcholinesterase activity by regenerating the phosphorylated acetylcholinesterase, and the continued till the patient is clinically better. The dose is about 1 to 2 gram, that is 20 to 40 mg per kg, as 5% solution over 5 minutes it can be given. As a continuous infusion as 5 to 10 mg per kg per hour can also be given. The maximum dose that can be given in a day, that is less than 12 gram in 24 hours. And it should not be the pyridoxine should not be administered in asymptomatic patients. And convulsions, if occurs, can be treated with benzodiazepines. And bronchospasm and acute respiratory failure can be treated with atropine, oxygenation, bronchodilators, and either electively intubate and ventilate the patient. Thank you.
Sometimes in the theory paper, this topic is asked in two ways. There may be a general question like discuss the management of organophosphorus compound poisoning. The other type of question I have seen in the papers is discuss the recent guidelines or advances in the management of OPC poisoning.
Okay.
So it is better that you prepare the answer from both these angles. What you have described is the classical OPC poisoning, which has been practiced for many years. But
Yes,
as you mentioned in the very beginning, that it can be ingested in the form of inhalation or by cutaneous absorption or by oral intake. Nowadays, these organophosphorus compounds are used as biological warfare equipments also.
agents. Yes,
And that is where you talked about nerve gas.
yes,
And
sir.
for this nerve gas, the conventional treatment is not sufficient. So they have included other type of drugs like gabacyclidine and more recent agents, which are able to immediately dissociate the binding between the organophosphorus compound and the acetylcholinesterase enzyme. You must talk a little bit more about how these compounds get attached to the acetylcholinesterase enzyme. What is the structural nature of this acetylcholinesterase enzyme? Where is it? It has got an anionic site and an esteratic site, and at which part it gets attached, and how, by what mechanism it may inactivates that enzyme so that there is no breakdown of acetylcholine in the body. So it is nothing but classical accumulation of excess acetylcholine, which stimulates virulently and vibrantly all the both the nicotinic and muscarinic receptors present both in the periphery as well as in the central nervous system. That is why you get all these features of involvement of the central nervous system as well as the muscarinic receptors in the heart and the respiratory. Did you mention anything about the effect on the cardiovascular system?
Yes, sir. It can cause bradycardia and hypotension.
So when you talk about sludge, it is a mnemonic to
Yes, a
remember
mnemonic
what is
for
happening.
vascular
But then
extent.
you must individually also describe what is their effect on individual system, especially cardiovascular, respiratory, gastrointestinal,
Yes, sir.
central nervous
Yes, sir.
system. Like that also, you must expand a little bit more in your answer,
Okay,
and
sir.
then talk about this things also. Otherwise, you have done a fairly good job of presenting this topic.
Okay,
So
sir. Yes, sir.
let me share my screen and